All right, so we're going to get things going here. So let me introduce our guest for the evening. Dr. Ashley Brandt is a board-certified obstetrician and gynecologist and is also a fellowship-trained gender-affirming surgeon. She's the medical and surgical director of the Gender Affirming Program at Reading Hospital and the Tower Health System, where she also serves as teaching faculty for both the Department of Obstetrics and Gynecology and Plastic Surgery. She's the director of Gender Affirming Services at Reading Hospital, where she provides hormonal therapy, routine health services, and gender affirming surgeries for transgender patients. She also happens to serve on the board of directors of the Mazzoni Center in Philadelphia. So she is an ally and a friend. And with that, welcome, Dr. Brandt.
Thank you. And a community member. I identify as, my pronouns are she, her, hers, and I identify more gender fluid, and I am engaged to a very lovely female midwife that I met at work. So
perfect.
But really bringing everything full circle. So let me share my screen. There we go. So I'm going to talk tonight about redefining the role of the gynecologist in transgender health. My background being an OBGYN and then transitioning, no pun intended, into gender affirming surgery, I think my perspective in gynecologic care as it relates to hormone therapy, surgical procedures and things like that is a unique one. And, I think it's really important that patients and the general public and providers really understand how important the role of the gynecologist is and how important care we can provide to all of you. So I'm going to go through, sort of introduce our program at Reading and Tower Health so people are aware that we have services here and what we offer. I'm going to talk about some healthcare barriers that transgender and gender diverse patients face in seeking OBGYNs, and talk briefly about the role that we have in both the treatment of transmasc individuals and transfeminine individuals. I'm going to skip through some slides. I'm actually presenting a very similar presentation at the Trans Wellness Conference. And so some of this won't necessarily be relevant to the talk for tonight that I want to focus on. I do have no disclosures. So I'm just going to click through this. So I just want to talk about the program at Reading. So in 2015, our program at Reading has existed predominantly for hormonal services and routine wellness. The LGBT Center at Reading in Berks County reached out to Reading Hospital leadership and have partnered with family medicine, psych, and other specialties to develop a hormonal and routine services program. The program initially started, unfortunately for better, for worse, in a women's health center, which I'll talk about why the language of that can be problematic, particularly for transmasculine patients. But we did need a starting block here. Excuse me. And then they initiated our EPIC system, which is our electronic medical records, and created a program that actually takes into account sexual orientation and gender identity, which you'll hear termed SOGI, potentially at other conferences or in hospitals, that takes into account and will show up in your chart and take into account sexuality, gender identity, body parts that patients have. And this is as broad as having your gallbladder removed to whether patients have had gender affirming surgery or not. In 2019, I was hired right out of fellowship. I did my fellowship at Hahnemann Hospital right before its closure. May it rest in peace. And like I said, my background's in OB. Since I've been here, I've initiated and partnered with urology, urogynecology, plastics, weight management, spiritual care, psychiatry, and anesthesia to really provide very comprehensive medical and surgical services for patients that not only involve hormonal therapy, not only involve routine health maintenance, and obviously the gender affirming procedures that I perform, which is the vast majority with the exception of facial feminization, but to really make sure that my patients, whether they're pre-op, post-op, or never want surgery, really have the comprehensive multidisciplinary needs met. So OBGYN kind of gets a bad rap that it's this very binary specialty and focuses predominantly on one gender and one biologic sex, which isn't actually true. Both our governing bodies, so ACOG, or the American College of OBGYN, and the American College of Nurse Midwives, both have formalized statements and have taken great initiatives to really talk about how OBGYNs should really, be prepared and really develop these services to take care of gender diverse and transgender patients. So there's a lot of pushing right now and a lot of education happening in the world of OBGYN to really serve these patients. So what can an OBGYN do? In my opinion, quite frankly, everything. So we can provide basic preventative services. We can screen for sexually transmitted infections, screen for cancers, depending on the body parts that patients have. We can provide hormones as well. Hormones is the premise of OBGYN, and so applying hormones to the opposite gender is not complicated at all, in fact. So discuss family planning options. OBGYNs do this all the time, talk about contraception and provide prenatal care. And so I think this part is not emphasized enough in talking about family planning and OB care for the gender diverse community, because this is one of the cruxes and one of the things that I think people really, really should be aware of. We can take care of transmasculine and transfeminine patients before and after surgical procedures. And in some cases, with appropriate training, we can perform gender affirming surgical procedures. Everyone I'm sure here knows who Marcy Bowers is. And she, in fact, is a gynecologist and one of the most incredible pioneers of gender affirming surgery in the country. So I'm going to talk briefly about education and discrimination. I'm not going to focus on all points of this, but LGBT issues, and particularly transgender issues, receive very scant attention in medical training. They fortunately have gotten a tremendous amount of attention, even since I finished fellowship in 2019. And, you know, when I was in fellowship, 2018 to 2019 was my fellowship, and there were hardly any papers. There was hardly any guidelines outside of the WPATH standards of care to really talk about surgeries, talk about medicine, talk about hormones, and what sort of long-term treatments and long-term things look like. That's definitely changed, but it's not changed quickly enough. Particularly in the world of OB, a lot of generalists don't receive training on caring for transgender patients, and many were unwilling to perform appropriate exams on transgender men and women, mainly because they didn't know how or were unsure of screening recommendations. Skip these next two. There are a lot of myths, I think, and this isn't just particular in the transgender community, but even the LGBT community as a whole, of not needing to go to the OBGYN. There are many good reasons. I, being, like I said, a patient who has partners that have been only women and hate going to the gynecologist, despite the fact that I am one myself, there are a lot of reasons why we delay going to the gynecologist. One, visits and even a waiting room, depending on the images in the waiting room or sitting next to a bunch of pregnant women, can really exacerbate gender dysphoria. And genital exams, of course, can exacerbate dysphoria. Patients who don't engage in penetrative sex think they don't need screening for cervical cancer or sexually transmitted infections, which is obviously a myth. Patients who have stopped having bleeding while taking testosterone may not think they need gynecologic care. And exams may, in fact, not only be painful themselves, but also bring up painful or traumatic memories. So what can providers do? I think a lot of this is education. So a huge part of what I do is educating other providers, medical students. I lecture all across regionally and nationally to really talk to providers about how they can serve the community much better and how to be sensitive to these concerns. So pelvic exam, and I think as a patient, unfortunately, a lot of transgender patients have to inform providers on how to care for them. But I think as that education disparity gap narrows, I think it's really important for patients to, and again, this is dependent on the provider, to know what makes you uncomfortable. And I hope that providers that patients go to are taking into consideration what makes patients uncomfortable, and to have that dialogue before an exam even starts. I think it starts with not making assumptions about a patient's gender identity, sexual practices, or sexual orientation. It's my job as a provider to really talk about the purpose and health benefits of the exam. And when I first meet patients, unless they're coming in for a problem that they want addressed, say a post-vaginoplasty patient's having an issue and she's a new patient from an outside surgeon, I'm not asking patients to, I'm not performing a general exam on patients. If a patient requests that, that's perfectly fine. But for me, it's really important to establish that level of trust and connection with the patient and have them feel comfortable in the office environment and the space with my nurses before even doing an exam like that. And so there are things, and at every exam, especially if they need, if a trans guy, for example, needs a pap smear, I will always play music. I am a DJ. I've been a DJ for 15 years. I shockingly still do it. And I will always offer to play music and have patient pick a favorite song if it's more relaxing to them. To self-insert a speculum is an option. So I offer that to cisgender patients as well. And I think if that's something that makes you comfortable, you should most certainly, if your provider doesn't offer it, ask if you can. Also, there are self-swabs for certain sexually transmitted infections and even HPV. So providers should offer that. If they don't, you can always ask if that's an option, because that's a really, really great option. And then making sure, you're using a small speculum, lots of lube. Can't emphasize, there's never too much lube. And, sometimes just start small, like start with a exam, with a finger, make sure that the patient's okay and comfortable. I think using gender neutral language during exams is really important. Unfortunately, there is very binary language when in medicine. And I think there are definitely ways, as you can see here, to take terms from gendered to least gendered. I personally always start with least gendered terms. When I'm talking with patients, I'll say monthly bleeding, how's your chest, things like that, internal organs. So patients will often correct me if they're comfortable using more gender terms, but I really try and use the most gender neutral terms possible. So why is gynecologic care for patients assigned female at birth important? And I say assigned female at birth because I want to make sure that I'm being very inclusive of the non-binary population or patients that may not identify as transmasc or transfemme. So I'm going to use AFAB and AMAB terms to take those patients into consideration. So gynecologists, like I said, can provide hormones. We can provide pelvic exam, treat benign gynecologic conditions, the gender affirming surgery that I'm trained in. So I particularly am trained in mastectomies, hysterectomies, and the metoidioplasty and phalloplasty, although I'm not offering a phalloplasty currently. Contraception and family planning, and screening recommendations. So we can really, really do a lot. So I think, you can take, where patients are getting hormones from an endocrinologist, seeing a primary care doctor, seeing a therapist and a surgeon, you can kind of combine 3 of those things into one in some cases. So myths about T. All of these things are false. So testosterone does not increase a risk for breast cancer, does not increase your risk for uterine or ovarian cancer, doesn't increase your risk for cervical cancer. So I think these are important to know because there's a lot of misinformation out there. I think that's the dilemma right now of at least in the past year or two. And so if you see that, there's a lot of great data and a lot of great papers out there that kind of disprove all of these things. So I'm going to skip through these. These are more medical. So I do want to talk about hysterectomy in patients assigned female at birth. So I think, and WPATH agrees with this statement because they make this statement, that all gender affirming procedures and gender affirming treatment are medically necessary. We have these known benefits, those known physical benefits and known mental health benefits and just known quality of life benefits. And so these are medically necessary procedures. However, and this more comes from WPATH standards of care really come into play, not so much in the fact that things like hormones are necessarily medically necessary before surgery, but from an insurance standpoint. So insurance coverage, a lot of these procedures are now covered by insurance, and insurance companies use the WPATH standards of care to define how they should cover things. And so if a patient desires a hysterectomy for gender dysphoria, then they need two letters from 2 separate mental health providers and to be on hormones for a year. Now, testosterone, as I said before, there's really, as far as increasing effects of cancer causing any detrimental effects to the uterus, there's no medical reason why someone needs to be on testosterone to have those organs removed. So there's no medical reason for that. Same thing with top surgery. They've removed that recommendations for patients being on testosterone for top surgery. but you do need a letter from a mental health provider. If a patient needs a hysterectomy for a GYN reason, say there are fibroids or there's an issue with the cervix or just people are having bleeding on T and no medical treatment's working, then that you don't need a letter from a therapist. So I think these delineations are really important. And there's a bunch of different recommendations on the how procedures should be formed. Laparoscopically is the most common kind. But, for patients that are seeking, any type of bottom surgery, like a fallow or a meta, and are worried about scars or worried about sort of having scars that may look more feminine or more in line with a hysterectomy, and that can exacerbate dysphoria, a vaginal hysterectomy is an option. And then as far as keeping ovaries or not, this is a huge debate. I really let patients kind of dictate this option, to be perfectly honest with you. We know the effects that keeping ovaries, even in menopausal ladies, cisgender patients, have on bone health, cardiovascular health, the bone health being the big one. We really have no idea what removing ovaries in a 21-year-old trans guy on T will do. And because testosterone actually also prevents osteoporosis. So as long as patients are on testosterone, they're really not at greater risk for osteoporosis, even if those ovaries are gone. Some patients don't care if they're there, others want them out. And so it's a risk-benefit analysis for me. And the importance is just really counseling. Some debates right now, does testosterone and stuff that I've seen or stuff that patients have asked me, does testosterone increase the risk of thromboembolic disease? Not really. It increases the red blood cell mass and it increases the hemoglobin levels, which kind of makes the blood thicker. So that's why there may be an association or correlation with that, but not really causal. So we ultimately don't really know. Should we stop testosterone prior to surgery? So this is up in the air. I attended the WPATH conference this past year and it's like 50-50 split. So this is still being debated. Some patients who want surgery, some surgeons will say we don't stop it at all. Others stop it a week or two prior to surgery, just because of that supposed correlation with thromboembolic disease. So really, we don't know. And again, as far as surgical route for hysterectomy, again, it's a risk balance and risk benefit. So some things I think that are really good pearls for patients and people to be aware of is testosterone is not reliable contraception. So if you have a partner that is assigned male at birth and has not undergone any gender affirming surgical procedures, or you're having a patient with penile vaginal sex, you need to counsel, patients should be counseled the fact that T is not contraception. Because in fact, 33% of people got pregnant on testosterone. So, and any method that cis women use is appropriate. But again, you want to take into consideration, and I take into consideration patient comfort. So for patients who, an IUD, which is a device that goes into the uterus, some guys just don't want that, don't like genital exams. It's really awful for them and hard for them. And so, I offer it and say this is an option, but it's not an option that's the only option. So there are things like this thing up here, the Nexplanon, which is a little implant that goes in your arm, which works really, really great. So I really, again, believe in having a very tailored conversation and a very democratic, so to speak, conversation with the patient, and really let people know their values, know what makes them comfortable, and every trans experience is different from person to person. And I can simply just provide the medical information and the options out there and, let patients really kind of guide their care and what they want their lives to look like. Screening. I love these posters. I actually really want them for my office. So screening for sexually transmitted infections. This is based really sexual behavior, the parts that you have, and risk factors. So it's kind of the main gestalt for the slide. And then you'll see here, this is more medical. There's a debate about the birth control pill, that it's not really first line because there's theoretical concern that the estrogen in the pill may counteract the effects of T. So I really don't, it's used first line in cis women all the time, but it's not really offered as much in trans guys for this reason. And this has known thromboembolic risks, by the way. So I talked about the IUD. It's really, really great. And the implant, which is that Nexplanon that I showed. So I think this is a really, really key slide for patients and providers to know, because this is a body parts directed screening. And so If you have the tissue there, if you have the organ there, it's important to screen for it. So if patients have not had top surgery at all, regardless of whether or not on testosterone, it's still recommended for patients to have breast exams and screening recommendations as they apply for cis women. And there are multiple organizations that decide the screening guidelines. The age is typically between 40 and 50. If you have a history of breast cancer or personal history of cancer, those guidelines may change. But in general, this is a recommendation. If you've had a mastectomy, regardless of whether you're on T or not, just chest wall exams. You don't need a mammo. It's like so many great things about top surgery. As far as the cervix, so if patients haven't had a hysterectomy, regardless again, whether they're on T, the pap smear should follow the recommendations for cis women. If patients have had a hysterectomy and there's no prior history of any abnormal severe pap smears within the past 20 years, you don't have to worry about it. Another beautiful reason about the hyster. As far as the uterus and ovaries, whether or not you're on T or not, you don't need to screen for them. So I kind of touched briefly upon the gender affirming surgeries. So the breast and chest surgery, the term top surgery, the bilateral subcutaneous mastectomy or the double incision is the most common one. It has the lowest revision rate. It's really great for patients depending on breast size, skin laxity. So if people have been binding for a really long time and have, big breasts, this is the incision. If patients are a little on the heavier side, this is also one that can really help get and prevent any dog ears. Periareolar, or the keyhole, sorry about that. It's my DJ ringtone. I'll silence that. The periareolar is really reserved, the keyhole is really reserved for patients that are younger with very small breasts and have like very taut skin elasticity. The buttonhole is very similar to the keyhole in terms of skin elasticity and breast size, but it's for patients who want to preserve nipple sensation because the other two don't preserve nipple sensation as much. So that may be the reason if you have surgeons that recommend one over the other, or you see one over the other. Dr. Scott Mosser has a great chart as to why you pick one over the other and really great videos online. So I think that does a really good job of explaining it. The genital surgery or bottom surgery, hysterectomy and removing the ovaries counts as bottom surgery. It's something that I do very commonly, that any OBGYN can do, in fact. The metoidioplasty, which is essentially creating a microphallus. There's that simple meta, which we actually performed a meta at Reading last week, which went great. But the patient didn't want any urethral lengthening. He wanted to still be able to sit down to pee and wanted to keep the vagina. So just created a microphallus with normal sensation. But you can lengthen the urethra. You can put in testicular implants and create a scrotum. Phalloplasty is creating an adult male-sized phallus that you can use for intercourse and to pee while standing. We do not offer this here yet, but hopefully this is something we will offer within the next few years. And then you have virilizing procedures, liposuction, PEC implants, and all that good stuff. So as far as patients that want top surgery, again, it's not shocking that a lot of patients want top surgery. As far as the bottom surgery, again, more trans guys have, at least statistically, have wanted hysterectomy and have had hysterectomy. And when you get to things like the meta and fallow, the complication rate is so high. It can range anywhere between 25 and 75%. So it's just more technically challenging. Creating that urethra is a lot harder. And so there's risk of stricture, fistula, things like that. So even though a lot of patients may want the procedure, a lot of people don't have them simply because of those complications. So I hope in the future, there'll be a lot of innovations in technology that can help reduce these complications, since we know what they are. They're just very hard to prevent. So this is sort of an example. This is one of my patients. This is a 3-month post-op, but I give this guy a lot of credit. He lost like 60 pounds in 8 months to get this surgery, and he was phenomenal and one of the sweetest guys. So, but you see with the sort of the tautic breast, it's really from binding. The nipples are pointing essentially to the ground, and then he had a double incision, and he's very, very happy. This is a patient that I operated on very recently, as you can see. Again, very, very similar situation. Each of those breasts actually weighed about 5.5 pounds. So aside from that, he had so much back pain and was just so happy that those were gone. The goal of the double incisions also, as you can see, to sort of highlight the pec muscle and the pec shadow. If you have a lot of breast tissue, so you don't get a central dog ear, which is possible if you have skin here, you can sometimes make these incisions meet in the middle. So I'm going to sort of switch hats here and talk about gynecologic care for patients assigned male at birth. So again, GYNs can provide hormone therapy, do gender affirming surgery, again, with the caveat of appropriate training, because that's really, really key. But people can most definitely care for vaginoplasties after surgery, provide routine screening and contraception, health maintenance, and family planning. So what do we offer here at Reading, and what are some gender affirming surgeries in general? So the breast or chest surgery, so bilateral breast augs, which I do, and they look great, and patients are very happy with them. The general surgery, so you'll see the single or double stage penile inversion vaginoplasty. I only offer the single stage penile inversion vaginoplasty, but I was trained in 2 different techniques actually. And the colonic interposition, so using a portion of the colon to create the vagina. The peritoneal, which is very common in Mount Sinai and becoming more common, I believe, nationally, is using the lining of your inside, the peritoneum, to create the neovagina. And then, of course, there's bilateral orchiectomy, which is the simplest of all the genital surgery procedures, which is just removing the testicles. As far as FFS, I don't offer FFS because I'm not plastics, like fully plastics trained. My fellowship was a plastics fellowship, but I don't do facial feminization, liposuction, voice surgery, the trach shave, and the BBL, which looks awesome. So again, similar to patients who are assigned female at birth, a lot of patients have undergone or desired breast augmentation. It's a pretty simple surgery with a low complication rate. As far as genital surgery, the difference that you'll notice here compared to the AFAB patients is that more of these patients undergo some type of bottom surgery. The complication rate is lower, and there's a lot less urethral complications and things like that. And it's not a complication-free surgery, because no surgery is complication-free, but it's just a much more perfected technique. So what are complications? This is not a patient I operated on. This is a referral from another surgeon. I have to put that disclaimer. So complications that can happen. I think it's really important when you are picking a surgeon is to ask about, if the surgeon doesn't talk about the complications, which personally should be a red flag to you as a patient or a friend of a patient, a partner of a patient, is ask about the complications. I'm very upfront with patients because no surgery is complication free. And, you know, my whole motto is, you know, plan for the worst, hope for the best. And the more informed patients are about something that is so life-changing and so wonderfully affirming, I think the better your relationship will be with your surgeon, and you'll just got to have a better experience, I think, overall. These complications are rare, but they do happen. So the most common one is sort of wound dehiscence or necrosis. So suture lines opening up, things like that, because you can divide complications into minor or major. Granulation tissue almost always happens. It's just a healthy overgrowth of tissue. This is very easy to treat. Labial asymmetry, again, you tailor surgery to what patient's skin has, body habitus has. If labia are asymmetric, it's very easy to revise things like that down the line and give patients more labia or less labia. Bigger ones. So I think another very complication, these two go hand in hand, is the vaginal stenosis and loss of depth and difficulty dilating. And I think, you know, it really should be emphasized. I actually have patients come in for a couple of visits to really talk about the new anatomy that they're going to have, how that's different from anatomy that they currently have, even something as simple as what an orgasm experience is like. It's obviously very different. And I think talking to patients about that and setting those expectations and saying, these are what, you know, normal vulvas look like. This is how an orgasm will differ than what you currently experience. This is how peeing will differ from what you're currently experience. So I think talking about that anatomy and having multiple conversations about what to expect after surgery, and not just the surgery itself, are so key, honestly. So vaginoplasty aftercare. So this is something that I do all the time. But I think it's important for providers and patients to know they don't have the same tissue or the same anatomy as someone who is born with a natal vagina. The tissue, so it's, if you're using the penile shaft skin and scrotal skin, It's the same kind of skin that you see. It is not as susceptible to things like gonorrhea or chlamydia, because that's the natural vaginal tissue is made from what's called mucosa. But skin is susceptible to things like melanoma, which is a big one, herpes, like things that you would normally see, syphilis, chancroid. So because that skin is different, that tissue needs to be thought of a little bit differently when your patients are getting examined or when I'm doing an exam. Unfortunately, a lot of the vaginas are not self-lubricating. So, and because patients are dilating using lubricant, because the prostate is left in place, there may be like this debris, secretions, again, from skin. You have glands in your skin called sebaceous glands, which release sebum or an oil. And so you may have that kind of discharge as opposed to like a classic yeast infection that you may have with a natal vagina. Yeast infections and infections can definitely happen, but those aren't the more common causes of discharge. Unlike cisgender vaginas, because they're not self-lubricating and have different microbiome, that's why douching is recommended. Again, everybody has different douching protocols, but that's why it's recommended. Oh, excuse me. Dilation. This could be like a whole separate conversation and a whole separate talk. This is the hardest thing about a vaginoplasty. This is the most important part in post-op care as a patient and as a provider. And this is the hardest part of post-op care. And so every surgeon and every center has different protocols. And I will say, and I have a textbook right next to me that could verify, there's no one dilation regimen that's been proven to be better than the others. So if your one surgeon in California says, well, I have my patients dilate 4 times a day for 20 minutes for the first month, and a surgeon in Philadelphia says, I have them dilate twice a day for 20 minutes for the first 3 months, that's not abnormal. If you follow the protocol that your surgeon has given you and go from there. Pains during dilation is not uncommon. Again, I'm not sure how well this is emphasized. I can only speak from experience from fellowship, but I think it's really important to talk that it can be uncomfortable, but there are definitely ways to mitigate that pain. Pelvic floor therapy has gotten a lot of attention lately, which I love coming from GYN world. I did a lot of this in residency, and I'm not surprised that it has shown to be very successful in patients undergoing vaginoplasty. And it's actually better to even start this before the surgery happens. And I think it's really important if you're having difficulty dilating, talk to your surgeon. If your surgeon's out of the area, find a surgeon in your area. And again, the earlier you talk to somebody about difficulty dilating, the better your outcome will be, because there's a lot of little tips and tricks that we can give and help to make the process easier. So care. So how does granulation tissue? I said this is a common thing. So how do we care for it? It often will be sometimes bloody with dilation or this yellowish blood-tinged discharge. It often will go away on its own. If it doesn't, you may have people say, well, we can treat it with silver nitrate, medical grade honey even. Sometimes the topical steroid cream or ointment. Rarely does it need surgery. Fistula is the biggest one and the most feared one. This can present as air, stool, or urine in the vaginal canal. The big thing is to, communicate if you're a patient and experience this, to talk to and call your original surgeon right away. Again, you want to, if you're a patient, a loved one, or a provider, you want to talk to that original surgeon or find someone with experience with trans surgery and the type of surgery that's done, because not every person and not every provider is familiar with this care, and you don't want to go to a center or a person that can potentially hurt you or hurt your loved one, or you don't want to be a provider that is extending beyond your skill set. So STI screening. So again, this is very similar. So it's body part, risk factors, and what you're doing. Pretty much a good thing. And then the difference with contraception though, so estrogen and the blockers can cause a decrease in sperm production. However, patients can produce enough sperm sometimes to cause pregnancy. So again, use condoms. It's like my line that'll be on my tombstone, use condoms. Again, health maintenance. So body part directed and organ directed. So if patients aren't on estrogen and, you have a breast dog, which you shouldn't be getting a breast dog if you haven't been on estrogen, because you're not going to get great growth, but routine mammography is not indicated. If you've been on estrogen you're over the age of 50 and have been on hormones for at least 5 years, you mammogram every 1 to 2 years. I anticipate these guidelines will change, quite frankly. So if guidelines change, it's because we have more information. So just make sure your provider is up to date on guidelines and that we're finding the right information. As far as breast aug, it doesn't increase your risk of breast cancer, although if you're using textured implants, there's a particular type of lymphoma. So just make sure you ask your surgeon, you know, does this type of implant increase my risk of this certain cancer? They'll tell you. We have to be upfront about that. I don't use the textured implants. I use the smooth gummy bear, so those aren't associated with that. The only thing it'll change for mammograms is instead of like the X-ray, a breast MRI is better. Just sees it better. And again, for the neovagina. So I think it's really important, again, and why I talk to patients about the parts that they have and the parts that they will get and compare them side to side, is that I've had patients who've had vaginoplasties and say, well, when I'm going to get my period, can my partner get me pregnant? So I think patients that ask those questions, it is perfectly reasonable. And it's the surgeons and people that are taking care of those patients really need to do a better job of really talking, again, about general anatomy, what it does, and what to expect after surgery. And so right now we can't do a uterine transplant. It's not to say that's an impossible, but we're still perfecting it in cis women, so it's not a thing yet. But there's no cervix, it's just a vagina. So pap smears aren't recommended yet, although they may be down the line, we don't know. But again, the prostate is not removed at the time of vaginoplasty, simply by virtue of where it's located. But the difference is that the prostate, and this actually will provide sexual sensation in addition to normal clitoral sensation. The prostate exam is performed through the near vagina and not the rectum, because now there's a space closer. I'm going to kind of go sort of through fertility preservation, just kind of touch on highlights. It's really important. Providers should be offering this to patients. There's a lot of misinformation still out there about LGBT communities and whether or not we should have families or not. It is everybody's biologic rights, regardless of your gender identity or sexual orientation, to bear children, if that is something that you want, and however you want to do that. So there are ways to do this. Before starting estrogen, it's important. If a biologic family, if you're strongly tied to having biologic family and being a biologic parent, to preserve your sperm before starting estrogen, because it's hard to say, we don't know. Some sperm counts recover after you stop estrogen, some don't. So it's, again, important for providers to offer that, but to ask about it. And there's a couple different ways, as long as you have the sperm there, depending on the gender identity and the biologic sex of your partner and what organs they may or may not have, there's a bunch of different ways you can have a family. What we don't know is how long you should discontinue hormones for. Again, for patients assigned female at birth, so egg cryopreservation, you have to stop T for this. I've done this myself as a self-disclosure. It's not fun. It's about 12 days of crazy hormones and transvaginal ultrasound aspiration to get the eggs. Very happy I did it. But my partner probably wasn't, because I would think I was crazy. But but this is a really, really great way. You have to stop testosterone before you do this, but you can start testosterone. And if you decide that you want to freeze your eggs down the line, that's fine. Testosterone doesn't affect egg production that we know of. So OB care. So we are hopefully within the next year coming up with an initiative in Tower Health to talk about establishing a prenatal and pregnancy program for the transgender community, using midwives who are phenomenal. Again, I'm biased. I'm marrying one. But I think that multidisciplinary care and offering obstetric and prenatal care for trans patients is very important. A couple pointers and highlights is testosterone's category X. So unfortunately, patients, if you're a trans guy or non-binary patient on T, you got to stop T when you're pregnant. But we have no idea how long you need to stop that for before attempting pregnancy. So some providers will say 3 months, others will say 6 to be safe. We don't know. Pregnancy, of course, can exacerbate dysphoria. So having providers that are very sensitive and informed about care is really important. The other big caveat is if your gender marker is male, your birth certificate, all that kind of stuff is male. Insurance hasn't quite caught up yet to this. There may be issues with insurance coverage. We can often work it out, but it's definitely something to consider. Delivery considerations. So I talked about uterine transplant, not yet, but maybe. For trans guys or for non-binary patients on T, is there an increased rate of OB lacerations because that tissue is atrophic? There are increased rates of cesarean sections? Not really. There definitely are slightly increased rates of peripartum or postpartum depression. So to monitor yourself and for your provider to monitor that. And then again, chest feeding. So this in of itself is dependent on surgery because as you can imagine, removing that breast tissue and reconnecting it, you're disrupting all those ducts, all that glandular and breast tissue. So it may be impossible to breastfeed or chest feed. And it can exacerbate genitus for you. Other patients, say if you've had a buttonhole or perioral, you're more likely to be successful with that. So I love this slide. I think it's probably one of the most beautiful slides, and I hope to see more families like this, especially as we start a program here. But I think it's really important to challenge gender dichotomies, not just about reproduction, in fact, but as with all other aspects of transgender health and care. So I'm gonna, and there are a bunch of questions that I think popped up. This is my email. This is my cell. That is, depending on the day, the first or second love of my life next to my fiance. She's very cute, my little dog, Alex.
Great. All right, so we do have a few questions.
Absolutely.
Excuse me. So the first one was specifically about your experience with surgery. So, and this is, I think, for trans feminizing surgery. So, you know, how many surgeries have you performed, and do you do revisions from other surgeons?
Yes. So in fellowship, I've done 100 vaginoplasties and assisted on 100 vaginoplasties. We just got the program up and running here. So we're starting out, but I've done some revisional stuff here, some more minor revisional stuff here, but it's been over 100 primary vaginoplasties. And I actually work with a gender affirming surgeon presently, who many of you know as continued education experience. So.
Right. And so just out of curiosity, so the question was like, in one of your slides, you mentioned like, you know, so if you have a problem with the fistula, for example, like, you know, go to the surgeon who did the work. But
it depends, I think.
Yeah.
Yeah. So because, and what I think is a really great thing about having a team here. And so we have a urogynecologist here, a urologist here, and a really great multidisciplinary team here. So your urogynecologists know how to treat fistulas, general surgeons know how to treat fistulas. I was trained to treat fistulas as a GYN and a little bit in gender affirming surgery. And so we have a team of people that know how to treat these complications. If for some reason, God forbid, they happen in one of my surgeries or they come from an outside surgeon, we have, because it's an academic hospital center with all of these specialties, so invested in care here that you have a lot of specialties that are involved and a lot of really brilliant minds that can fix most things.
Good. So it's a question around for people who are assigned female at birth. So the question is, should an 18-year-old transgender male have a pelvic examination and screenings for cancer?
So I'll break this up into two questions. So for patients, and if you're HIV positive, the screening for cervical cancer does change the game a little bit. So that's a whole separate conversation on HIV positivity and screening for patients that are HIV positive and PrEP. But for patients without those medical comorbidities or without any immune issues, the recommendation for Pap smear, for example, which is the screening, is 21. If a provider tells you differently, it's not true. So find a different doctor. As far as a pelvic exam, so no, I mean, even in cisgender women, if you're not having any issues and are just going and talking about hormones or going, and I haven't performed a pelvic exam on the majority of my patients until the age of 21. If there's an issue, like say for some reason their tissue from starting testosterone is really thin, they're bleeding or having problems, and then a pelvic exam is warranted, but not necessarily for routine screening.
And just, you know, out of curiosity. So, and this may be different for people with transmasculine or transfeminine experience, but what would, just for ongoing obstetrical care, right? How frequently should somebody visit their OB?
At least once a year. So in cis patients, once a year, and that stands true for trans patients. And again, the question of a physical exams are really like body parts. You have these recommendations, but they're in fact only recommendations. And so I think, and that's what trips up providers when they're used to treating cis patients and then they cross over into trans world or see a trans patient for the first time. They're like, well, we have all these recommendations over here. What do we do here? And as long as you're seeing a provider once a year and say, talking about health, a breast exam, may or may not be warranted. A pelvic exam may or may not be warranted, but you should definitely see an OBGYN at least annually. And the tests and the procedures and the physical exam that is done, again, is determined based on risk factors, hormones, age, surgeries that have happened or not happened.
And I think that's why it's important for when you are shopping for a doctor, right? You're shopping for an obstetrician, is that you ask questions. Do they have experience with transgender patients? Mm-hmm. Because otherwise, they think they might be walking in to deal with a cis woman, and they start to freeze as well.
Yep. Even in my own hospital system, I don't know why this happens, but even in my own hospital system, even my own department, there's a provider for some crazy reason getting pelvic ultrasounds routinely on my trans guys on testosterone not getting monthly bleeding. And I'm like, what's happening? First of all, it says my specialty in the chart. I see these patients with hormones, like, why is there no cross-provider communication? And second of all, like, that's not an indicated test. Patients on testosterone aren't supposed to be getting bleeding. And cramping is normal to a certain degree on testosterone. So like, that's not a problem. And so I think it's really important because an ultrasound can be very dysphoric for patients. I hate them. I hate doing them to people. But finding a provider that's sensitive, for me, when I have to do an ultrasound on a patient, like let them insert the probe, or I can do a transabdominal ultrasound. And so even in our own system, there's this miscommunication, and it's unfortunate. And we need to have a better system for patients to find competent providers. There's just not a great, like, one website to go for patients, like in each specialty, like who does gender affirming surgery, who provides great mental health, who's a great endocrinologist, family doc, like, gynecologist. We just really need this running list of people.
Okay. So here's another question kind of related to what we're talking about. So, and you may not be able to handle this one in this particular setting, but it says, my endocrinologist is looking into a diagnosis of congenital adrenal hyperplasia for this individual. They're having long and heavy cycles 1 year in, and their T levels have been zigzagging off of the charts from 135 to normal for a cis dude, it says. The doc is recommending a hysterectomy and an IUD, but the patient's not sure that that's what they want to do. So what are your thoughts? And it's okay to say that you can't do a diagnosis via Zoom. So
I can't do a diagnosis via Zoom. I will say, so it brings up the question, actually was in one of my slides that I skipped over, talking about abnormal bleeding in patients on testosterone. And so T levels, the biggest thing with addressing abnormal bleeding, uterine bleeding, is the gynecologic term, is for patients on T, it changes the game, but not 100%. So most patients achieve amenorrhea at 6 months, but it can be on average a year or 18 months sometimes. And so personally, I'm not really working up, and there's no great definition. Like, we have a really great definition in cisgender world, gynecology world, but not a great definition in trans world. The definition that's been proposed, if it's been going on for over a year, you have normal testosterone levels, you're not missing doses, then you start going down the path of, I'm going to work up other things, like an ultrasound is indicated, certain lab work. So like looking up CAHs and ruling that out is not inappropriate. You're looking for things like PCOS or polyps and all of these other endocrine disorders, coagulopathy disorders. And so again, it's hard to make a diagnosis, but it's not unreasonable if someone's been over a year having abnormal bleeding. But the treatment, again, the hysterectomy should not be first-line treatment unless a patient wants it. But there are medical treatments that an IUD is appropriate depending on what the cause of, because that's really great at regulating bleeding. But personally, just at least knowing the information that I have, and again, I'm not making a diagnosis, but the T levels aren't in the therapeutic range. And so personally for me, I would try and play with getting the testosterone levels in the range, which the recommendation is between 300 and 1,000 or 300 to 800 on the literature. It's cis male range. And so if you're in that cis male range and you're still having bleeding, then for me, do I have to go up on T, down on T, or is there another problem that needs to be worked out?
Well, and I think it's also a really important point is that it's good to get second opinions.
Yes, that's
right?
the
And so
long and short of it.
Yeah, get a second opinion might be a good idea. All right, so we're switching over to the other side.
Okay.
So how often is douching recommended for trans women?
Oh, that's a great question. And similar to dilation, we have no like hard and fast recommendation. It really depends on the amount of discharge. So some people will say, some surgeons will say daily, some will say once a week, some will say, every other day. There's no set protocol.
Okay.
It's not a great, probably the answer someone wanted, but it sort of falls in line with dilation. Like,
yeah, follow your doc's recommendation.
Yep.
Along the same vein, how does the depth of a transgender woman's, the neovagina, compare with a cis woman's vagina?
So surgeon recommendations, so they actually measured, this study would have been so interesting to do. There is a study done on what the average length of a cis female vagina is. I have no idea how that gets approved or how that gets done. I don't want to know, but the study was done. The average length is in a non-aroused state, so a normal sitting, resting state, the average depth for a cis woman is 4 inches. When aroused, it's about 6 inches. Now, surgeons will often talk in centimeters, so that conversion is confusing. But the surgeon's goal is to get between 4 to 6 inches of depth. So, and what I really tell people, this is my little awful joke, but I tell people, like, I tailor vaginas to, I'm a very big feminist, so I tailor vaginas to the person, not to the penis. So I'm giving you a vagina in the depth that is recommended, like based on your body habitus, the skin that you have, and what a cisgender woman on average will have. If you get more, awesome. If you get a little bit less, maybe, we can work on that with dilation or pelvic floor therapy, but I'm very feminist. So I make a vagina that fits you based on the recommendations.
By the way, we're going to have a pelvic floor specialist in a future workshop here. I'm actually having a conversation with them tomorrow.
I love them.
So, okay, so let's see. Somebody asked if there's going to be a link to the slideshow for review. We are recording this presentation, and so it will be on our YouTube channel probably by Friday. So a question around neovagina. So can the placement of a neovagina be corrected if misplaced, and how would that be done? Do you offer revisions to open a vaginal canal that's closed? Yeah,
so it's hard to know what someone means when they ask like the misplacement, because there's a very limited space between where you can go. Like there's really only kind of one space, or you're like into the rectum, or another space where into the urethra. So that actual space that a neovagina is created is the correct space, if that makes sense. Sometimes the pelvic floor may be tight. Sometimes, if there's an issue with dilation or pain with dilation, or with how the body heals, sometimes that can cause obviously stenosis and things like that. So, we offer revisional surgeries at our center. The number of revisions the safe amount of revisions has not been defined. There are some surgeons that will do for vaginal stenosis. External cosmesis has a lower complication rate. The more revisions that you have, the greater the chance of a fistula or really injuring something is. And so for me, I have a particular rule just for myself. I'm a younger surgeon, and so, I'm not like Dr. Bowers. So I have my comfort level, and every surgeon has their comfort level. So if I do a vaginoplasty, there was an issue with dilation or whatever, patient has a stenosed vagina, I do a second revision. Beyond that, I'm going to refer out for, if someone has already had a revision, then I'm going to say, look, I really, go to the people that are writing these things, because I just have a certain comfort level, because I don't want to run the risk of injury.
And I think it's also really important that, again, you need to have a physical examination with the surgeon in order to really determine what kind of can't happen.
Yeah.
So let's see here. How long after vaginoplasty should you have your first appointment with a gynecologist?
Ooh, also a great question. These are great questions. Typically within a year, because you're going to be following with your surgeon in some capacity for the first year after surgery. Some surgeons will follow for 3 months, some will 6. I follow for the first year after surgery. Typically, I think a year after surgery, 6 months to a year is a safe spot.
Okay. We're going to try to do 3 more here before we finish up. Hopefully we can move through them quickly. So a question is, I had vaginoplasty, male to female, confirming surgery 6 months ago. After a second month, dilating has been harder and harder. They've lost depth and width. Are they still on time to gain it back, or is it too late?
I am a very hopeful person. I don't think anything is ever too late. I think letting that surgeon know that you're having issues dilating, like ASAP. And if you don't get an answer that you like from that surgeon about different tricks or techniques, I mean, there's different, there's not just one dilator that it's made. I mean, I think some of the ones, the picture, I think, of the sole source dilators, and they work great. They have the notches. I think they're easy for people to see, but they hurt. I mean, they are solid. I mean, I feel like I could kill somebody with those things. I mean, they're so painful. I can't imagine people using those after surgery. So there are different types of dilators that are a little bit softer, a little bit more malleable. So it may be switching up the dilator, or using lidocaine gel, using lubricant, losing something, seeing a pelvic floor therapist concurrently. So I think there are a number of tips and tricks. It may not be, if you lose an inch, you may not get that back with dilating with the initial surgery. But again, if you're only 2 months out, it depends on how much depth this has been lost. It may just be a tight pelvic floor. It may not actually be a loss of depth. Yeah. So I think there are a number of different evaluations that you could have and different tricks. But at 2 months, I do not think it's too late, unless people have completely stopped dilating and then that.
Yeah, but actually, this was 6 months. I might have misspoke.
Yeah.
But pelvic floor is so important, and people kind of think about it like, well, is cis women, doing Kegels, but everybody should be doing Kegels.
Everybody, right? Everybody should be doing Kegels.
And and there's other exercises as well. So we're really excited to have that specialist coming on.
Yep.
So as a post-op female, when can you expect to have spontaneous sex without having to warm up with a dilator first?
Ooh, that's very person dependent, to be honest.
Yeah.
Yeah. Typically surgeons will I recommend waiting at least 3 months to not have intercourse or any type of sex intercourse, vaginal, anal, self-stimulation for 3 months to let everything heal. It's really person dependent.
And lube is your friend.
Absolutely. Lube is your friend.
Yeah, absolutely. All right, last one. I have low growth hormone and take growth hormone injections to get my levels to normal. How would testosterone affect that?
Ooh, that's more of an endocrine. I would have to look that up to answer that. That's definitely more of an endocrinology question.
Yeah.
I would have to go to the books to look up.
So we are going to have an endo on in a couple weeks, speaking specifically about masculinizing therapies. So come on back for that one, and that might be the perfect question to ask. Yeah. So, Ashley, thank you so much for coming out tonight. Thank you for being a wonderful ally, a wonderful community member. We wish you all the luck in the world as you launch the new clinic and the new practice. And thank you so much.
Of course. Thank you so much for having me and for all the incredible work that you do. I have a bunch of flyers that I pass out to a lot of my patients. So I am very, very proud.
More and more
I know.
referrals from your neck of the woods. So yeah.
I will say, I will end. I am extremely, extremely passionate about making sure that the community is well informed about the care that they receive, and they receive compassionate and comprehensive care. I think the tables are really shifting, that there are enough people out there offering hormones and surgery and treatments that, find the doctor that fits you. I'm not for everybody, not every surgeon's for everybody, but be honest with yourself about what you want in a provider and what you want your goals are, and find that provider, because they're definitely out there. And yeah, so I wish everyone on the chat the best of luck as well. I'm very happy that people are here, and happy end of Pride Month.
Absolutely. Happy Pride.
Happy Pride.
Bye, everybody. Thank you so much, Dr. Brandt.
Thank you.
Bye-bye.